So Amy, if you're able to start that, that would be great. Um, and if anybody does not want to be on, this is the time to sign off. So with that, here with Dr. Steve Sears again this morning. Thanks for joining, Steve. We have CME as usual. Email goes to covidcme@dhhs@maine.gov. We just passed the end of another month, so I suspect that Gail Began from the MMA will do another round of emailing folks for an evaluation, which is how you get your credit. We're going to be talking about the latest data on clinical trials related to the new vaccine, which is Johnson & Johnson, or sometimes referred to as Janssen or Johnson. And with that, I'm going to pass it over to Dr. Sears to walk us through some of that before we get to some state updates as well.
Great, thank you. So just reminding everybody that we have lots of different types of vaccines, viral vectors, nucleic acid, and protein. The Johnson & Johnson is a viral vector vaccine. Can I actually move it for you? Can. And this is the best schematics we've seen, I think, which come from the New York Times. And so basically, you've taken some genetic material which codes for the spike protein, putting it into an adenovirus. The adenovirus does not replicate. If you recall, adenos cause generally cold symptoms, but these do not cause any symptoms. They're just a vector to bring the genetic material. It gets taken up by the cell. It goes to the nucleus. The DNA from the coded segment to produce spike protein is released. It then gets read with mRNA, and spike proteins are made, which are on the outside of the cell, which triggers our immune response. And it's really a pretty robust immune response overall. This was approved, as we all know, a couple days ago. It's had efficacy that was seen all around the world at a 66%, in the US, 72%. Why is that? Probably because this is a time when variants were increasing. So some of this is South African data. But I think the important thing we've said before is that it's 85% effective against preventing severe disease. And somebody asked last time, what's severe disease? So if you actually go to the EUA, it lists what severe disease is. And it's what you'd sort of think. It's basically if you've had greater than 30 breaths per minute, greater than 125 beats yes, greater than 30 breaths, greater than 125 beats. If your oxygen saturation dropped below 93%, and then all the other things that would go along with mechanical ventilation or needing some form of ventilatory support. The important point, I think, is that the determination of severe and critical was made by an independent adjudication committee using these very specific criteria overall. It's 100% effective preventing hospitalization and death, and that's really great. That goes along with some of the other vaccines we have. The other things that are really good about this is it's a single dose. It doesn't require cold storage. You can stick it in the fridge. That allows for more rapid vaccination of large groups and the dissemination of this. What does it contain? It contains some salts, sugars, the adenovirus, and it does contain polysorbate 80, which we're not sure what that means. We really don't think it's highly allergenic. It's in a lot of other things. It doesn't contain thimerosal, mercury, fetal cells. It's not made in eggs. It doesn't have latex. It doesn't have preservatives. It doesn't have pork products. It doesn't have microchips, and it does not have polyethylene glycol, which makes it different than the mRNA vaccines of Pfizer and Moderna. Next slide. This is pretty small, but if you look at the yellow line, this is looking at Moderna, Pfizer, AstraZeneca, Johnson & Johnson, Novavax, which is probably the next guy coming along, Sputnik, which is the Russian equivalent. It's a adenovirus 26 and adenovirus 5 mixed together. They're all 100% protective against hospitalizations and death in all of the trials. And that is probably the best thing we could ever have expected from these vaccines. Next slide. This is a nice side-by-side comparison of the trials and of it's Pfizer, Moderna, and J&J. And so, as we know, the Moderna, Pfizer, those are mRNA vaccines. This is a viral vector. The trials were all robust. The efficacy was found to be 66% overall, but 72 in the US. Minimal adverse side effects, but I don't want to say no side effects. It's basically similar to what we've seen with the mRNA vaccines. It is a single dose. It's only 18 years and older and can be stored in a regular old refrigerator. It's a good vaccine, and I think we want to start emphasizing that. There's a lot of people out there counting efficacy points, which really is probably not the right way to look at this. The efficacy numbers are better in the US than they were globally, but that's really just for disease. That's not for, it's for getting like mild COVID overall. The efficacy of the vaccines the different trials were done at different times with different variants in different places with different characteristics. So it's hard to completely characterize and compare both of them overall. Um, but I think if we go back and keep, reminding ourselves that for severe disease and death, this is 100% effective in preventing that from COVID. And it's a single dose, easier to take without the refrigeration requirements. We're going to be able to distribute this to a larger geography and to more places and more opportunities for people to get vaccinated. So it's a great addition to our armamentarium. And now so this is the third vaccine. We probably will see a fourth in a couple of months, but this is what we have right now. But even with that, it's going to increase the capacity in Maine and the capacity around the United States to vaccinate more people more quickly than we've had before. Next slide. I think it's yours, Lisa.
Yeah, great.
Let's
Thanks, Steve. And I'll just add on to this last one. The intent was for clinicians, for you all to have an easy set of talking points put together for your patients. And actually, I think I need to add one on here, which is to your last point, Steve, the more people we can vaccinate, the adding to the armamentarium makes it such that we have better ability to vaccinate more people, which is the fastest way to end this pandemic. So again, we do post the slides, so if it's easy to have a set of talking points, because patients, I'm sure, are already asking you and will continue to ask, should I really get that one? I want to wait for this one. So to be able to have some easy reference points for that. We do continue to be concerned about the need to promote vaccine equity. And as we're getting more vaccines out there, certainly it's important, but we know from data that's being tracked in the CDC, and you can see we're still having issues, particularly in some of our rural or most rural counties. This one actually makes Aristic look a little better than it is. The darker the color, the more people vaccinated. But what this doesn't show is the percent of people who are eligible for vaccines. So it doesn't show, because we know Aristic had a lot of older adults are doing pretty well, but they're nowhere near as looking as good when you look at percent of 70-year-olds vaccinated. Some of the rim counties look even worse. So certainly continued issues with trying to make sure we get vaccine out equitably. And then certainly recognizing that diverse populations, this is a system for tracking racial, ethnic data. And if you click on the plus of each the plus sign before each race, it'll drop down to ethnicity data as well. We certainly have some gaps there still in terms of even reporting racial ethnicity data at the time of vaccination. And then in terms of percent, this also, again, doesn't show percent. So some work to go there. There are efforts going on within DHHS. We've got several clinicians signed up to help with community outreach efforts, certainly address these issues internally. We've got Liana Amayas on the call, who helps to lead some of those discussions and efforts at DHHS. I think there's some efforts going out through Maine Care with outreach and letters, but once we get a look at that data, my guess is we're going to have more work to do there. And then there's been some really great work partnering with community groups such as area agencies on aging and other community groups that are really doing fantastic jobs with outreach, assisting with transportation and otherwise. Referenced a couple of times making patient level information available. We've got several available and translated 10 different languages. But always need to keep an eye on that. The other big update from the state perspective is everybody's seen, I'm sure by now, the governor's announcement last Friday about moving the prioritization strategy to a straightforward age-based strategy, which starts tomorrow, officially though, I suspect it's been this week, but so 60 and older in March, and then with the hope marching through the different 10-year age bands month after month, assuming that we continue to receive adequate vaccine supply to meet those demands month by month. We anticipate that hopefully vaccine will be ultimately authorized for younger people as the vaccine manufacturers continue to expand efforts to study safety and efficacy in children, but don't know that yet. But if so, that would be sometime this summer. We also continue to encourage practices to come together that are interested in um, distributing larger doses of vaccine through our community collaborative proposal. We've referenced, I think, previously on these calls that, again, when we post these, the link is live. We do now have Walgreens and Walmart offering vaccine at about 70 sites across the state. And then the federal agency, HRSA, is supposed to be starting to distribute doses to some FQHCs in Maine, just 2 to start, but starting this week. The website for the state is being updated, but again, just reflecting, we still have phase 1A, but we really believe we have been through most of those right now. So we're going to be directing, unless people are newly employed, we're going to likely be directing them to just follow the age bands. Just trying again to make things as simple as possible. Again, all information is on the governor's website. This has been, before this had the phases information that's been updated as well to those age bands. And then the sites continue to be posted there. Continue to post our information on the web, and we're going to break for questions here. So I'm going to stop sharing. And Amy, if you had a chance to tee anything up, or others.
Dr. Sears,
Yeah.
once all the staff and residents have been vaccinated in a facility, has there been additional guidance around mask wearing and testing coming out from the federal government?
Guidance has not changed at the moment. We probably are going to, what my guess would be, it'll be several months before we see final guidance as things change. But that a lot of that will have to do with the percent of penetration of vaccine and a variety of other factors. Right now, everything is really the same as far as testing and mask wearing.
You know how J&J does in the elderly population. There's been concerns about the AstraZeneca vaccine over the age of 65.
Yeah, the J&J appears to be equally effective in elderly. If you look actually at their EUA, I saw the question, so I pulled it out, and there were 6,800 people in their vaccine side over 60, and about 5% over 75. And so they had a pretty good proportion of people that were tested, and it appears to be as effective at the moment. I don't know that I've seen it all the way broken down to, to answer that completely, but everything that I've seen suggests that this is surprising. I don't know why AstraZeneca is showing that, but this appears to be effective across all age bands and all of the people within all the subpopulations that were tested.
I don't know, Cheryl, Lichty wrote an additional comment on that. If you want to chime in there, Cheryl, at all.
Yeah, I mean, it's just interesting. I mean, I think there is limited representation, particularly in the frail elderly, but this is kind of analogous to what happened with the Pfizer and Moderna trials. And there was a significant dissenting voice at the ACIP meeting back in November, December, when the decision was being made about who to prioritize first for those vaccines. And specifically, there were 1 or 2 very smart people who said, maybe we shouldn't prioritize the nursing home residents because we actually don't know how good these vaccines are in them. And, the decision was made to just go ahead and do what we did. And of course, the results have been truly miraculous for the nursing homes. So, I mean, I think we do still have to learn a little bit more about the frail elderly in particular with J&J, but I'm hopeful, very hopeful about it. And then again, also J&J has announced that they're looking at the value or lack thereof of adding a second dose in some populations. So it'll be interesting to see how that pans out.
Do you know if Maine tracks Maine residents getting vaccines from other states? I have not seen that. I don't know, Steve, if there's any.
I haven't seen that either. And so I don't want to say absolutely no, but I have not seen it, and it's a pretty hard thing to track overall, given the rapid expansion of vaccination. Theoretically, it's supposed to be given to, I mean, people should be in their state of residence for vaccination.
Are vaccine sites working at capacity, meaning are all available appointments being filled?
Cut out a little bit, Amy. Say that again.
We're
Or I can
wondering if
find it.
vaccine sites are working at capacity, are all available appointments being filled? That'd be a question for the sites. I don't know if Dr. Jarvis is on from Northern Light. If you
Yes,
have
I saw him.
Yeah, I am on, and not only working at capacity, we're working above capacity in most of our sites. Yeah. So, what happened was I got out in the media that there were appointments available, but once that announcement gets made, those appointments go fast. Northern Light alone filled over 5,000 appointments in less than 2 hours on Friday afternoon after the governor's recent announcement, and we continued to do the same thing on yesterday. So when there are appointments available, it's usually those lagging at the end of the week, but they are all filled.
Question about age-based criteria excludes the disabled and chronically ill. Is there any chance of adding vulnerable patients to the criteria?
I would say it's fair to say that there are ongoing discussions about that. I think, the governor's decision to prioritize by age band was based on the strength of the data of death from COVID related to age, which tracks down, through several of those age bands. That said, certainly, there's a lot of concerns being raised by other populations, whether it's certain high-risk medical conditions, disabilities, et cetera. So, I think it's ongoing conversation, but right now there's not an immediate plan to go on the age bands. Though I also saw a question about teachers, Amy, and do you want to talk a little bit about that? There was a question of prioritizing teachers or vaccinating teachers as priority.
Right, there's plans being worked on right now with the State Department of Education and the vaccine sites to provide access to teachers in their age band that is currently being worked on each month. But to set aside some dedicated clinic time for them, that would be hopefully Friday and Saturdays, maybe Sundays. So we're working on that right now, and we should have more information out to the teachers and the 60-year-old and up age band by the end of the week. So there's a lot of people working on that to try to make sure that there are appointments available for them.
So to be clear, it's not breaking out of those age bands to prioritize all teachers and staff, but it's prioritizing teachers and staff for access to vaccine within the age bands and actually setting up clinics in schools or otherwise.
Yeah, I also, I would want to remind us all that the goal is to vaccinate everybody. The question really is how to best do that and how to do that as equitably as possible. And there's a lot. I mean, if you look around the country, there's a lot of different ways that those decisions are being made, and as that's one of the advantages now of adding another vaccine, we'll be able to vaccinate increasingly larger proportions of the population. And so it's as Dr. Shaw has often says, it's not if, it is when, and that's will be moving along more rapidly now.
Are you hearing anything about boosters being done with influenza in one shot in the future? For COVID?
If I interpret the question, is that kind of are
Yeah,
there going to be
Combine it.
combined? Yeah, there's talk about that. The Moderna, I know, is working on that. But that's because they've been working on an mRNA influenza vaccine. Those aren't licensed, but there's a lot of talk of trying to put that together. There's always been discussion about trying to find a universal influenza vaccine. As opposed to sort of the multiple strains that we put into one shot now. But I don't see anything that's practically on the horizon. But it is a topic of discussion and a topic of some of the research.
with changes, it's still necessary to monitor for 15 to 30
Whoops,
minutes.
cutting out again, Amy, sorry.
Okay.
You want to try again, or I'm not sure which one you're on.
With J&J, is it necessary to monitor for 15 to 30 minutes post-vaccine?
Correct.
Yes.
I think that maybe I know it's on the slide. Maybe I went over it too quickly. There was one individual who had an anaphylactic type reaction, still not totally clarified. That was in South Africa after the J&J. And so at the moment, it's recommended for 15 minutes and then 30 minutes for people with severe allergies. We are hoping to get more data quickly on that and be able to move away from that recommendation so that yeah, we could move to such things as drive-through test vaccination sites and such things. But at the moment, that's where things stand.
Yeah, and I'll just expand on that to say that in the EUA, it actually points people to the exact same CDC guidance on allergic reactions as the other as the mRNA vaccine. So it's exactly the same thing. And I think some people were surprised at that, but given the newness and the at least even one anaphylactic reaction probably seems um, cautious, understandable. Although it does impact, things like drive-through sites and how people approach that. So
Yeah, and I think that one of the things that we're learning with Moderna, and we'll learn with this, is we will have literally millions of people vaccinated within relatively short periods of time, and gather a much more robust data set than what we've got from the clinical trials, which were good, but they're only in the 20 to 25,000 range overall. So this, it's amazing how many people across the country are being vaccinated.
Lisa, do you want to talk about are healthcare workers able to get vaccinated if they didn't get vaccinated during their facility clinic?
I thought you were answering this one, Annie. No, just kidding. Yeah. Yes, although as mentioned, we are trying to simplify and clarify that whole sort of remaining phase 1A. I mean, the bottom line is most phase 1A healthcare workers who work in healthcare settings or doing direct care have likely been vaccinated by now. From everything that we're hearing, we're not getting, tons of requests for that. But if somebody missed it for some reason or is new or newly returning to work and they truly meet the guidelines that they're working in a healthcare setting and doing either face-to-face direct care or exposure to potentially infectious materials that could cause COVID, not just any infectious materials, then yes. But we are trying to tighten it up a bit because honestly, we're hearing that the vaccination sites are spending so much time sorting out who's appropriate and who's not. And the feeling is, since most have likely been vaccinated by now, it's not inappropriate to send others through the age-based strategy unless it's very clear that they're, newly a nurse in, a hospital setting, something like that.
Yeah, Lisa,
And those clarifications will be coming out shortly from DHHS.
Yeah, Lisa, this is Jim, and I've heard this confusion a lot since Friday. This is an additive effect as far as expanding out who is eligible for vaccine. So it's not that 1As are no longer allowed to get vaccinated, or that people over the age of 70 are no longer allowed to be vaccinated. It's an additive effect, and it will continue to be that process for the foreseeable future. So we're just adding to who is eligible, not subtracting from who is eligible.
Though, Jim, with admittedly some tightening up that I think the department's trying to do in response to vaccination sites that's saying we're trying to figure out, do we really?
Correct, and
is
we
this
have that issue
person's-
too.
Right.
Is a dog poodle washer of a poodle that's a service dog, a healthcare worker, and so we don't want to do those things anymore.
Right. All right. Where are we here, Amy?
Any talk of setting J&J aside for employers, especially the essential ones?
I have not heard that. The strategy so far is to, when we get vaccine, to get it out and to get it to as many people as we can within, as I said, within those age bands to start with. Just to give you some sort of idea about that, there's 190,000 70-plus-year-olds, approximately the same number of 60 to 670s, and then approximately the same number of above 50. So you're talking about 600,000 people out of the adult population of 900 plus thousand or so. So the goal will be to, with this strategy, to get a very significant proportion of the population vaccinated.
Yeah, and I'll just chime in behind that again to say that's, related to the similar answer I gave before, which is it is truly a shift. So yes, before there was phase 1A, phase 1B, older, and then critical infrastructure, et cetera, and then 1C. So that's gone now, other than to Jim's point, we're not vaccinating 1A anymore. We are as new people come in, but it is truly a shift of all those other phases to this age-based strategy. So again, there's been questions, discussions about do you still, sub-prioritize within some of those. I think those are ongoing discussions, but right now it is everything else is moved into this age-based strategy. And again, that's based on the data about risk of death related to age, even beyond the, very old. Since I'm in the next age band, I had to say that is not very old.
The idea when testing will be completed for 12 to 18-year-olds.
Amy, why don't you take that one?
It sounds like you, Amy.
I mean, the Pfizer study is fully enrolled. Moderna was having issues getting enrollment, but I think they're getting close. I think we're hearing summer, fall, but it may be sooner. And I just saw that J&J's starting to do studies around really the younger infants and above. So hopefully we're looking at summer, but we don't have a definitive time frame yet.
And I saw one up above, Amy, that it sounds like a question about boosters. When do maybe do providers who got vaccinated in December need a booster? Maybe is the question. Not yet.
Not yet. Not yet. Not clearly determined. I think all of us who look at this and think about vaccines in general will likely think we're looking at boosters for next late fall, winter, but that's totally unclear at this point. The long-term data on these vaccines efficacy is being gathered as we go now, because that's one of those questions that we will need to answer. Probably wrapped up in several different characteristics. One is how long does the immune response last? What's the memory of our immune system, and then what's the changing nature of variants, and what does that mean as far as needing to potentially shift the some of the specifics of the vaccines. So more to come on that.
Great. And then one question missed the answer about having to wear masks. Yes, still. And can residents go out with family members who have been vaccinated? That's probably a longer answer related to long-term care. We will be talking in our long-term care medical directors call tomorrow more about that. And then there was a question about have people with COVID been part of the study? Were people with COVID included in J&J? Do we
Yes,
know that?
yes,
Yeah.
they were. Yeah, they were. I actually looked at it. It's probably about, off the top of my head, 15% or so thereabouts, because they did, and those were generally just randomized, and there was no specific difference. Interestingly, I think there's been a lot of data presented against smaller studies, but with the other vaccines, with people who had COVID, the booster response for the first dose seems to be really robust. And so there's some question about whether, it won't make a difference with J&J since it's one shot, but with the other ones, the question is whether one is sufficient for people who've had COVID. Unclear, but the short answer is yes, they were included.
All right. And with that, it's 8 o'clock. Seeing one more, is there durability for J&J? I think we just don't know yet, Charles. It's just coming out right now. So I think we're going to have to, as with the others, wait and see. So thank you all. 8 o'clock, we will wrap it up. We have recorded it again. We, as always, post the recording and the slides to the CDC website. We'll be doing another version of this on Friday at noontime as usual. And then back again, we are still going with weekly right now. We will probably ratchet these back a bit, maybe after March or in a few weeks when hopefully things slow down a bit. But thank you all for your continued interest and participation, and we'll see you next time.